Oi, pessoal, eu sou a Bia.
E eu sou a Jackie.
Bem-vindos ao ReMindcast. Hoje a gente está aqui com essas duas celebridades. No nosso estudo, no nosso mundo científico, é o John Searle e o Jay Shah.
E nós estamos muito felizes por poder tê-los aqui no Brasil, mais uma vez aqui conosco, e nós vamos fazer algumas perguntas aí sobre o mundo da dor crônica.
Jay, John, so nice to have you here. How are you feeling today?
Very good, thank you.
Yeah,
Yeah,
excellent.
it's a great day.
Great day.
Mhm.
Are you tired?
No, actually.
No?
Ready to go?
Ready to go?
Ready
Okay,
to-
so
Yeah.
we're going to ask you some questions about pain and study of pain and how you feel like Brazilian studies comes with you, eager for learning and their background and everything that you think about that, okay? So, in your opinion, what has changed the most in the way that we understand chronic pain over the past few years?
So I think you were speaking about us as
Yes,
a
you
group
too.
and what we're doing. So
Yes.
I think what's influenced us a lot has been the desire to learn and understand more about mechanism of pain and then how we can translate that into clinical assessment and treatment. And because that helps inform what clinicians do, how they assess patients and their outcomes as well. So it's been, for me personally, transformative because it allows us to be much more rigorous and targeted with respect to our patients' chronic pain. Because chronic pain is such a nebulous and confusing and complex entity, right? And I like to say, like almost like layers of an onion, we're trying to peel them away, trying to find for each individual patient what are the components of their pain.
Mm-hmm.
Yeah.
Yeah, I think what I've noticed is a keen interest, like Jay said, in a multidisciplinary approach. So I'm finding that a lot of different professions now are beginning to listen and work together. Much like today, we had a multidisciplinary group, and we're learning from each other. And again, there isn't a myofascial expert, so I think by learning, everybody, we all have to learn from each other, and I think there's a greater interest in sharing ideas and coming to these types of interdisciplinary conferences to learn mechanism and methods of management.
I guess we still have some mistakes about this when you have to recognize which mechanisms are involved in the myofascial pain or in chronic pain.
Right.
And what are the most common mistakes you see in the management of chronic myofascial pain and central sensitization? Because this is your expertise.
Yeah. So I think one of the biggest problems is over-medication and prematurely starting patients on a variety of medications before they go up the pyramid, so to speak.
Yes.
Right. We are we hope to be the non-pharmacologic experts, or at least strive to be that, understanding the importance of utilizing non-pharmacologic treatment. And that encompasses everything, both physical and psychological. Right?
Don't you think the big problem is that the physicians are still the only the prescriptors?
Prescribers.
The prescribers.
Yeah.
And they must have to move to change this position, to start to what we talked about later.
So, yeah, this goes back to something that he said it's really about bringing multidisciplinary together, right? Because unfortunately, too many physicians feel that they are the authority about pain, and so this is knowledge that should be contained within a certain professional sphere and not shared, right? And I think it's important that we all recognize what we can learn from each other, right?
Yeah, I think one of the biggest mistakes is, and we talked about it today, is that when you treat the patient, for sensitization, many clinicians stop there. They're very often not looking for the primary pathology. And so, I think that's the next step. And that really is because we really don't understand the mechanism yet.
Yeah.
I think we're getting there. So that's a big, medication is another example. We'll give them medication, they're out of pain, but what is driving this phenomenon? What is driving this chronic musculoskeletal pain? And we've talked about many possible options: spinal degeneration, joint dysfunction, visceral pathology, and so on. So I think the next level of treatment needs to go beyond just treating that symptom and then looking for the cause.
And that leads to my next question. We don't have to focus only on the technique, right? We have to focus on the clinical rationale
Right.
and the mechanisms and so on.
Yeah.
When did you realize that?
I had an epiphany for myself more than 26, 70 years ago when I tore the peroneus brevis tendon in my right ankle working on a Nordic track machine. And at that time, I was a jogger, and I figured, okay, I'll get it surgically repaired, and then I'll go back to jogging. And I found that even after it was repaired, these were longitudinal tears, yeah? So I was in a cast, non-weight bearing for 2 weeks, but I was in the cast for 6 weeks. And then when it came off, my leg was like a block, frozen, right? And that affected my gait, my mechanics in my foot and my ankle. And I started getting chronic pain on the opposite side first, and then on the same side. And I went to, I don't know, countless clinicians, therapists, acupuncture, everybody that treats chronic pain. No one was able to help until someone suggested, why don't you identify and treat the segment? In your case, it was, my case, it was L5S1. And like the proverbial light switch, it literally took one treatment to see an effect. This is after 4 years of chronic pain. One more, and then it was it. And then I returned to normal function. And I could not believe that it was that simple. And the other thing that shocked me so much was I went to see the top specialist at Johns Hopkins, and he was very dismissive. And I thought to myself, wow, if he is this way with a fellow, with a colleague, who's a clinician, physician, imagine how he must be treating patients when he doesn't know what the pain is and he just dismisses and says, there's nothing wrong with you. It's like it's in your head, So for me, the personal epiphany, understanding the segmental connection. And the reason I emphasize that is because I had lots of myofascial treatment. Nothing was working. But you treat the segment and it was remarkable.
It was when
Epiphany.
you started to be
Yeah,
productive.
it really took off because I was fascinated by trigger points, and there was Lynn Gerver who said we need to assess the local milieu in some objective way, and let's look at, can we use microdialysis? And that's what we were able to do. That's how we did our first studies, and then we did clinical studies using, we did imaging studies. We did clinical studies looking at needling, etc. So it's been a wonderful journey, and I may as well keep going because I'm going to allow him to talk in a second. But then when our paths crossed, it was in 2011, and I was giving a lecture at the Canadian Memorial Chiropractic College, and he happened to be in the audience, and I quoted him. Or I mentioned one of his papers, and he said, "Oh, I'm that person." And he
Nice.
said, "I've read your work." And I said, "I've read your work." And and since then we've been like this. And it's been,
And you became best friends.
we became great friends and just colleagues, and just, it's like it's a professional marriage.
And the irony is
Yeah.
that we came from kind of different pathways,
Yeah.
and we had the same thinking.
Right.
And I drove him to the airport that day. He canceled his Uber. I said, don't take. And we
Yeah.
just started speaking about
Right.
myofascial pain as
Right.
if we had known each other for
Yeah.
30 years, right?
Yeah.
And and it's interesting how we both kind of converged onto the same
Same thing,
idea.
the neurogenic.
Yeah.
I was already thinking neurogenically because of the neuropeptides, the segmental component, and I thought, well, he's already published this neurogenic hypothesis. So, and I said, what's his background? Oh, I see, he's a neuroscientist. Oh, but he's also a chiropractor. This was fascinating. But then our personalities just clicked. I mean, we just like I said, as you can see, barati barata.
So what you were saying now is that one key for the treatment of patients who has a chronic pain
Yeah.
is to understand and to investigate the central sensitization
And the psycho-emotional component.
yes.
Because I sorry, I'm hogging it. Please jump in, you want to. Because this
The
goes.
podcast is only with me and
Yeah, no. This goes.
Me
This
and
goes. This goes back to something that Deja said. Deja said. Because this is so important. You have to remember, how old was I? I was must have been my early 40s. I have young children, and I'm already thinking, I can't run with them. I can't play with them. I'm having chronic pain in my feet, and I was depressed.
this changed your
It
behavior.
changed everything. It changed everything. And I thought that, okay, this is going to be my life now. I'm not going to be able to walk pain. I was to the point where I was leaning on walls. I was sitting down all the time. It had such an impact on me. And then when the epiphany happened, when this was done. And what's even more remarkable, which I have to say, is I was in touch with this guy named Mark Fraub, who's an acupuncturist I think in British Columbia or somewhere the West Coast. I was in India at the time, and I'd read his work, and he was doing a lidocaine injection into acupuncture points, segmental points. So he said, try this. So my brother-in-law, who was an anesthesiologist, he said, oh, that's the medial branch of the posterior primary rami. So he just did a simple injection and poof, poof. I said, how can it be this simple?
Yes.
But this is the reality.
And everything made sense for you.
Well, not everything made sense, but it started
to make sense.
It started to make sense, and it began this journey of seeking and questioning, and because there you get great results, but it also patients don't improve. Why? And this
that
is
poof that you had,
yeah.
you had that effect on us.
Yeah.
Few years ago.
Few years ago.
That
Interesting.
was what moved us to do this.
Yeah.
The courses and the study and the promoting the
How do you feel about this?
yeah.
The change you did
It's
in our lives.
I have, it's, how do I explain this? For me, I didn't realize it until you verbalized it, honestly, because you have been coming to so many meetings over the years, shown a lot of interest, a lot of curiosity and enthusiasm. And I was just like, I said, that's great. That's wonderful. I'm so happy to hear that. And as we were discussing earlier, John and we like to work with people who are like-minded, who are curious, who want to teach, who want to inform, who want to advance. We both would love it if what we're teaching students would learn.
Yeah.
Why are students not learning the basics of what and please, I'm going to shut up so you talk. Because no, this is not good.
Now you have the mic.
I please talk about the entire manual you've developed that you're teaching at Guelph. Yeah, please. This is great.
Well, I mean, I don't know where to carry on. What was the question?
No, never mind. Just keep going.
Just keep going.
Yeah, no
well,
question.
Jay, just to add to that, again, the treating patients is really where, all science begins with observation.
Yes.
That's where it all begins. So, and that's kind of my story, is where I just started seeing things that I couldn't explain using standard Western biomedical jargon. I had to find out. So that's when I went back to school at the ripe age of 37, actually, to pursue a graduate degree. And I really didn't think that I would end up where I am today. I thought I was going to enhance my knowledge and my skill set and so on. And really, the research just kept opening doors and opening new avenues and giving me, shedding more light on this problem. And I realize now, that there's much more work to be done, but we are really hovering over the target now. I think that the way we're evaluating patients, some of the outcome measures we're studying is really teaching us how to get down and measure, specifically, sensitization, wind up, and then how to treat it, So we need to understand why we're doing things. And then, as Jay said, mechanism-based outcome measures and treatment. I think that is really improving the patient outcomes as well. So it's exciting for those of us who've treated this condition, because we're having a massive impact on these patients now.
Mm-hmm.
Yeah.
Right. Yeah. And his is a truly remarkable journey, right? Being in the
Yes.
clinical practice for so many years, observing things, questioning them, starting a master's and then going to a PhD and then like this, shooting off. And the great thing about this, as you both know, I think everyone in this room knows, there's not that many people who are studying this.
No.
It's a relatively small group.
Yes.
Despite the burden,
Yes.
it's
Yes.
huge. Everybody has it, but no one understands it very well.
What's your opinion about that?
Yeah.
Why?
What?
There's so
It's
few
too hard.
people.
It's too hard. The problem is too difficult in most cases to study. I mean, and we see it. Again, we're studying. I was actually studying it really at the spinal level in my PhD.
Right.
But then now, as our group is expanding our framework,
Yeah.
we're going back to the supraspinal effects,
Yeah.
and that is difficult to measure, as we
Right.
heard earlier
That's
today.
we heard. Yeah.
So it's a very challenging problem, and there's much easier problems as a scientist to solve, right?
Oh, okay.
Right.
So you're saying that the methods to prove your point
Yeah.
scientifically
But
is
you-
difficult.
I think you also have to be passionate about this. So what got me passionate about this is that I was seeing these patients, and I really wanted to help them. So I needed to understand how the mechanism works. So you have to be passionate. Certainly, if you're doing a PhD, you have to be passionate about the question.
Right.
So that's really what drove me as well. Is I had the connection to the patients, I had the observations, and then I went in. Now I had some questions that really meant a lot to me personally, and that's what why I
Yeah.
kind of moved in that direction as well. Right?
Yeah. And also I think it's who was saying about you want to go where you want it. People would like to learn and are curious, want to. So going back to these associations, these friendships, these relationships that developed over the years, first Sergio inviting me, right? Coming here, meeting Lucy, right? Meeting both of you. And slowly but surely the circle has been getting bigger and bigger and bigger. And I think it's so important that we all recognize what we don't know, what we don't understand. Be humble, right? And keep questioning, right? And know your limitations. And so I want to learn from other people. I want to be able to observe what they do, how they do it, and see if we can measure what changed in that person.
Don't you
So-
think there's a big hole or a big gap in the graduation of the physicians, of the physical therapists? Because we didn't have nothing about, we haven't
This is why
learned
That's why I was going to
about chronic pain
Mhm.
in the graduation.
This is
Yeah,
where
yeah.
what he's doing at Guelph and also the entire book, right, John? If you want to
Mhm.
share a little bit about the whole MSK thing you're doing with the injury model and as well as with myofascial pain.
Yeah, and I think to your point, and even new graduates from medical school and even chiropractic are not being taught this information because it's not well understood. Look at the small group here that we had. It's almost like a very exclusive club, and we need to
Yes.
get this out there. We need more people like you
Yeah.
to get this information out there,
Right.
and that's
But you
that
have,
is a problem.
when you study this, you should have to think
Out of the box.
out of the
Out
box.
of the box.
Yes,
No, I was
that's
thinking,
what I
but I
want
was
to
thinking
say.
out of the box because I saw this in the clinic.
Right.
That's again where science begins, right?
Right.
So I saw things and I had an idea what was going on.
Yeah.
Going into graduate school, and that's how science is done.
Right.
You have your questions and you go in, and then you test it in a lab or in a using controlled design. And again, this to me was I kind of had the answers. I think before I started, I just needed data.
Okay.
Yeah.
And to show I kind of get a sense of what was going on, and then
The data was necessary to prove what
Yeah.
you were.
step by step,
Yes.
right,
Yeah,
step by step, and we're still doing it,
Right.
but we kind of as clinicians know intuitively that what works and what doesn't, right? And I think that's kind of what's moving us forward, right? We need more people like
Right.
Jay,
Yeah.
myself, people that are
Yeah.
kind of straddling
Lucy.
both the research, Lucy,
Yeah.
but I'm saying research scientists, right? Because I
Right.
think that's really important.
Yeah.
It gives you that balance.
Right.
But tell us more about your manual, your book.
Well, I
Lucy.
mean, my course, I developed the course when I started working at Guelph, and it was basically, it's a health and injury biomechanics course. And so I thought, listen, I want to take the students, it's a 4th-year course, so I want to take them from cell to bedside. It's my journey, basically, right? So I take them from
Except your journey was from bedside to cell, and then
from
back.
bedside to cell and back. Yeah, good point. Good point. Actually, that's a good point. So basically what I do is I take them from the cell. We talk about tissue mechanics, then we move into tissue injury mechanisms, because I want to understand what's happening in the muscle. And then from tissue injury, we go into tissue assessment. So then I move into the clinical setting, and then I move into examples, like we talk about all of the MSK conditions and so on. There's a big module on pain, of course.
Sure.
Yeah. But I proud to say that I don't think there's another course out there like that. And then that's because, of the evolution that we've, as a group, got. We have a very unique perspective on this condition.
And then one of the things that we're also proud of as a group, both us as well as our larger group, is that we are very circumspect. We, in English, we have expression, don't get over your skis. Don't make claims that the data do not support, right? Number one. Number two, and I said that in the morning, I said, we're not here to try to sell or teach a technique. Really, it's really about how do you
It's different.
assess the patient, look at the whole person sort of approach, and use reasoning, use a mechanism to try to drive how you assess, and then how you treat. And I think one of the problems today is that because students are not learning what he teaches, and in all these professional schools, it's relatively easy for someone to claim, I have this technique, I do this, and someone takes a weekend course and now they do,
Yes.
and it creates this kind of false, perception that there's expertise. Yeah, there may be expertise in a technique,
In the technique.
but that doesn't work on everybody,
Yeah.
So
And it's not enough.
it's not, right? So I think,
when you don't know when,
yeah,
you should do that technique.
that's right.
Mhm.
Yeah,
It
you
doesn't
have to
work.
ask all those questions. Who,
Yes.
what,
When,
when,
when.
why, all those.
Yeah.
Well,
But I think even foundationally, I think one of the biggest things that is not out there is, again, we talked about today, primary versus secondary hyperalgesia.
Absolutely.
Pain is
Yeah.
considered as pain generally under
Right.
one umbrella, and it's
Right.
not. You can see that neurophysiologically,
Yeah.
these are two different, acute and chronic pain
Yeah.
are two different mechanisms
Right.
completely.
Don't you think that when now you have the neuromodulation, and that's why this is so important nowadays for us, because now we can understand that we have some different ways to treat your patients, because we have different ways, different kind of pain. And don't you think that's this is when you think about the pain, this way or that way, you can use neuromodulation, for example.
Oh yeah.
And
for
this
sure.
is this is nowadays a
But-
new.
Yes, but see, remember, this is important. This goes back to his point. Yes, you can neuromodulate the pain, but are you identifying the primary cause? The
Yes.
primary function. That
When
is,
when you consider this,
yes.
then the neuromodulation is useful.
Yeah.
But when you cannot understand which kind of pain are you treating,
Yeah.
Mhm.
So the
Right.
technique we use today with the dolphin,
Mhm.
that doesn't work for acute pain.
Right.
Nociceptive
Right,
pain.
exactly.
You saw the effect on chronic pain.
Right.
yes,
Secondary hyperalgesia.
Exactly.
So you have to be able to diagnose that. You have to
Yeah.
be able to
Yeah.
identify the difference between the two and then apply the proper technique.
Right.
You're going to treat acute pain very differently than you are chronic or secondary hyperalgesia, right?
Yeah.
Acute pain is inflammatory, you're icing,
Right.
you're
Yeah. And I think one of the things we have to make sure that for tomorrow the students understand, because I don't know if it came through today, John, that whenever you hear the word inflammation, you automatically think injury, trauma,
The 5 symptoms.
Yeah, like the
The 5
lower
signals,
color,
yes.
tumor, etc. We're not talking about that. We're
No.
talking about neurogenic, and I think we need to reinforce that just so they understand
Neurogenic
when they
inflammation.
hear inflammation. So that's those. There are many slides, as you know, that I wasn't even able to because she was on me the whole afternoon. That's clinical. Let's get it. I have so much. I had so much more to cover, because I wanted them to understand. But I think the good thing about ending the day today with a clinical assessment and treatment was that they now can see, oh, okay, this is what we're going to do.
Yep.
This is how we have to assess. And I told Erica, I said, please, tomorrow, as I told others, when you're in a group, please share with the group what you would do in your clinical practice if you observe something. How would you treat it? Because the wonderful thing about these type of courses is that, yes, we have small groups that are discussing amongst each other, assessing each other. Then you share it with everybody else. And you see so many amazing stories. The whole group can appreciate that. That's one of the things that I've been so privileged to get, to be a recipient of, is listening to that. Because it's like people say, oh, it's just, who was it was saying, she said, oh yeah, with Carla. It was Carla.
I
He
guess
said,
was Carla.
I started using this on Monday the next day, and she's the geriatrician.
Yeah.
I said, that's wonderful.
Mhm.
You know?
She's going to see a lot of it.
She's going to see a lot of it. Yeah.
Yes.
So I think, there's so many populations of patients, but clearly the
And
elderly.
I think one of the
elderly
exciting,
is the one.
maybe going back to an earlier question, one of the exciting things is, a few years ago with my animal model, my preclinical model, the relationship now between the spine and chronic MSK, actually have drawn that link. Now we need to obviously translate to humans, but I think, and this is something we see, age is a risk factor for both myofascial and osteoarthritis. So I sense that there is a very strong causal relationship between the two. This is quite significant certainly for chiropractic, but for physio, for all of us in terms of prevention, primary, secondary, and tertiary prevention strategies.
Yeah.
Certainly primary prevention that could maybe mitigate or reduce the prevalence of this in aging population. So I think that's a very exciting stream
Yeah.
that we all need to.
Yeah.
And the
You know,
age
with-
population
And
is
again,
growing.
going back to her
Yes.
question about
Mhm.
why is this not more readily known, except, but what's great in Canada is the impact his research is having on the Ontario Chiropractic Association. They are
Yes.
eating this up. I mean, really, really want to learn more. They want to start using this, the knowledge, both the preclinical and the clinical. So this is real. This is truly an exciting time.
It's
It's an exciting time. And
Congratulations
so for us,
for that, John.
for us,
for
it's
all of
like
you, all of you.
for us, we just want to keep moving the ball down the field, so to speak, using a football
somebody, we're not as young as we look. Somebody has to take over this soon. So it's exciting to have the two of you and Lucy and the group here actually in Brazil that's going to carry the torch. I think you guys are amazing people, and I'm so happy, and I'm very happy to come down here anytime to share ideas and continue this collaboration.
And how do you feel about your students here in Brazil?
Oh my goodness, it's been a joy, really. Every time I come, the enthusiasm, the feedback, the the questions, the interest, the curiosity, and then the eagerness to be able to then implement it
Yes.
in their own
Yes.
practice. And then a few like Bruna and others, that you hear from them in emails, and I did this. What do you think of this? Should I try this? So I like the fact that they're thinking about it now. They're using it,
Yes.
because to what you said earlier, no one learns this. I didn't learn this in school.
No,
I didn't learn any of this, It's
we don't
like
have
all-
this on graduation.
We don't.
We don't
Not
know.
even
imagine,
post-graduation.
Not even
Not even
post-graduation.
post-graduation.
Yes.
Isn't that remarkable?
When
Isn't
we
that-
started to think about to do this in ReMiND,
Yeah.
it's just to spread our knowledge and what we've learned with you. And we started this move us to go on and start to do this. A community to learn
Yeah.
and to improve the knowledge about the chronic pain, myofascial pain,
Right.
central
Yeah,
sensitization.
yeah.
I guess these words are key.
Right,
Yeah.
right, yeah. And I also think, going back to her question about the students, I think it's so wonderful when you can empower people.
Yes.
Because why do we all go into the health professions? To help others, right? And you don't, if you keep getting, minimal results or, equivocal, you want to learn more, do better. But I think what's great about this and what you two are doing is you understand it's not
Right.
about a technique. It's about a framework. It's about a model that is going to keep evolving over time as we acquire more and more information.
It's the way we
Yeah.
see our patients.
Absolutely. Tomorrow we're going to have an excellent lecture on magnesium. I mean, I'm
Yes.
so excited to hear that.
But you know what, my opinion? Every time I hear somebody said that I wanted to do this course or study this because I want to help patients. But I also think that we help ourselves being better persons,
Good point.
being better
Yeah,
humans,
right.
because it's a two-way treatment.
Yeah. Yeah.
Every
yeah,
time
yeah.
we do something good for someone else, it
Right.
comes back right to you.
Exactly.
Good as a
Right.
person, good as a
A
professional,
professional.
Yeah, yeah.
good
Yes.
as a evolutional, spiritual, whatever.
That's
It makes me a better person.
Right.
So
Right.
I thank you both
Our
Yeah,
treatment
for
changed
your hard work.
us.
Yeah, that's right. And actually, no, I was going to say, this goes back to something Dea said, because I asked her, I said, when you're working on the tissues, do sometimes people have like this emotional release? And we see that sometimes in the workshops where people don't realize how sensitized they are, and they are shocked that they've had chronic pain for so long, and how can it be this simple? How can it's not simple, this is a complex problem, but where there are things that we can do. And people go through stages. The first stage is like, and I went through this personally, like I was anger. Like, how could it be that I could go for 4 years? I'm a clinician, I'm a physiatrist. No one knows what's happening here. And it takes a conversation, an email with a clinician in Canada, my brother-in-law does this treatment. Now you can all say, oh, that's just a placebo effect. Okay, sure, it could have been a placebo effect, but again, I'm the person, it happened to me. I know what I felt. I know the change. So the only point I'm making is that it's what you said. You're helping others, but you're also helping yourself
Yeah.
as you age and as you undergo degenerative changes. So I've seen this over and over again. When I'm teaching, it's like it's an epiphany for the person that when they get examined, and they get treated, like, oh my gosh, if this can help
That's the
me
way.
so much, how can I help others?
Yes.
That's
No
the
matter the
next.
profession, it's wonderful.
That's our next project.
Yeah.
We don't want to just teach professional. We want to speak to a regular person.
Yeah,
Yes.
To
absolutely.
spread this,
Yeah.
obviously, in a different
Well,
level.
this goes back to what you did with that video that you made for the OCA, for the lay public. You want to share that?
Yeah.
Yes.
That.
I mean, I think, to your point earlier, I'll show that to your point. I think there also comes a time in everybody's career where you have experience and you've seen things, and you want to share. You become, as you get older, you become a teacher. As you become more experienced, you have something to teach. And I think, clearly all of us are kind of in that same boat. But to your point about the video, that's a lot of the translational work that we're doing is educating both clinicians, like you said, and
the public.
patients.
And patients.
Because
exactly.
patients need to know what,
Right.
a lot of them don't know what to seek out.
Yeah.
A lot of
What-
them should be seeking this out on their own.
If they're having hip, knee, shoulder pain and they're older, what's the first thing they say? My arthritis is acting up.
Yeah.
And this is
Nociceptive.
it.
This
Yes.
is nociceptive.
Yes.
Nociceptive. Yeah. That's the other way of saying it, right? That my arthritis is acting up. It's
Uh-huh.
nociceptive.
Uh-huh.
Yeah. So, but it doesn't respond to no treatment of it doesn't respond to anti-nociceptive or anti-inflammatory treatment. So how can it be nociceptive, right?
Are we going to talk about that now? What do you think?
That's a long story. How much
It's
time?
a lot. We have the whole
No,
night.
but I think this is an important conversation
It
because
is
we have
very
the-
important.
we have to just keep on doing the research, right, John? And the research should inform further studies as well as clinical practice. And if people want to kind of put their head in the sand and not look at new data, because this is where I think the myofascial world, if you want to say this is runs the gamut of clinicians of all kinds. Unfortunately, I think the Travell and Simons has been the go-to kind of, the what's the word? What do you want to say? Do you want to say it almost like they were the gurus, right?
I know
Of
you
the
are my
myofascial
guru.
world, right? Yeah,
You are
yeah.
our guru.
So yeah. But what I'm saying is that is it as if that is somehow been handed down. It's like there's nothing in that book that could possibly be incorrect or that you could advance or improve upon, right? Does that sound correct? In any
No,
field of study,
no,
right?
not at
So
all.
I think also, as you said, the group, we go to these international conferences. The group is a very small one, and it's the same people a lot of times. And I, in one of my presentations, I talked about the ratio of primary research to secondary review type research. It's a 2-to-1 ratio, not even a 2-to-1. It's a 1.5 to 1. So for every primary study that we produce in this field, we're producing a review paper. So what are we reviewing?
Yeah.
Well, what I think we're doing is we're creating an
We're just
echo chamber,
regurgitating,
right,
yeah.
in the field,
Right.
and the same ideas are keep going out.
Yeah.
And some of those people keep pushing the same ideas out. And in many cases, they kind of challenge new thinking, which again, a scientist will not do. They will, they'll debate it, right? So I think that's where we're at right now, where there's a lot of this sort of rehashing of same ideas. And so there's some new ideas that we're bringing in. And I think people are starting to understand that there's other ideas out there. that
We are
need to
trying
be-
to plant a seed.
Who
We
is?
are trying.
You are.
We are trying.
You're doing a great job.
Yes.
Yeah.
Count
Yeah,
on-
We are
absolutely.
count on
trying.
us.
So apropos of that, what have you two found with the physiotherapy association? What's the name of the association in Brazil? And what opportunities are there for you to go to a national conference, give a lecture, give a presentation, etc.? Because to me, that would be the lowest hanging fruit, is to inform your colleagues, right? But what opportunities are there for that?
Not much.
Why is that?
I don't know.
Here in Brazil, everything it's difficult when you think it's a big step.
Mm-hmm. To do what?
No, you have a big step. Here are the physiotherapists,
Right.
here are the physicians, and we have to move.
No, I'm
We have
talking about physiotherapy meetings.
I know,
Yeah,
I know.
yeah.
But when you want to explain for all the other physiotherapists, it's very difficult. We don't have money. We need to do some research to prove what we are thinking about, what we are doing nowadays. And this is very difficult.
Slow. It's slow.
Slow, yes.
Yeah.
And but I think me and Bia and there's a group, a small group that we are planting some seeds, but it takes time.
Yeah, I think we have to change some mindsets because they're still stuck on the
There you go.
biomechanical
There you go.
mechanism.
That goes back to what he just
They
said,
are
right?
still
Yeah.
stuck on
Yeah.
that. And
That's right. Yeah.
sometimes I feel we don't speak the same language.
Yes.
I was saying that to you
Right.
yesterday. So
Yeah.
I speak something and I hear something. I'm like,
So this
it's
is
a
so
different
interesting.
language.
I didn't
Yeah.
get to show the slide today,
But
but
we are
you've
the same
you've
professional.
seen this slide where the world of myofascial pain, the emphasis was always on the myo.
On the Maya.
Right? So Stecco was the one who said to us in the lecture, we've lectured with Antonio over the years several times. He said in the second edition of the book, of the Trigger Point Manual, the word fascia doesn't even appear. So, which shows you that it's been, to your point, a myocentric world of, so the focus was on the muscle. He and Carla, as their father Luigi, and others have brought in the fascia, right? And so there's all this new knowledge and information that is there for the taking.
but
And that's why
I
it
don't
it makes no sense to me that you could not bring in an Antonio Stecco to lecture at a national physiotherapy meeting, present all kinds of data
Mm.
show. You know what I'm saying? It to me, and if that is the problem, then to me it must be political.
Yeah, but if you think bringing someone who is a specialist on knee rehabilitation, wow, it's a big
Explodes.
yeah, it's
On
a
what?
big
Everything
thing.
explodes.
Knee
Knee
rehabilitation,
rehabilitation,
like
for
Yeah.
something,
example.
Yeah.
something like normal, regular.
Also biomechanical.
Come on,
Yes.
That's what you're saying. Right,
biomechanical.
Biomechanical.
Yes, the room will explode.
Right.
Like thousands of people. But when you say something like that, more reasonable thinking, mechanism
But I
thinking,
guess there's a problem,
they
Bia.
think they reach.
When we were students, fascia was not an
Important.
important.
No.
No.
And when we were when I was in medical school, fascia is what you cut through.
You cut
Yes,
through,
you
you
cut
know,
through
exactly.
trash.
Throw it away. That's
Yes.
right. Yeah.
Totally,
Certainly
yeah.
don't eat it.
But
That's why.
how-
That's why you think.
Do you think that changed? Now your daughter just graduated from medical
Oh,
school.
that's a good question.
Is it different?
Your
than-
daughter's
They
perspective.
yeah. I mean, I asked her about what they learned about
Anatomy.
neurogenic inflammation, anatomy. Of course, they do, but the whole concept of the role of fascia in myofascial pain, the innervation of fascia, actually. So, Antonio, we've had many discussions about innervation. They've done an amazing
Oh
job
my God.
opening that door, that Pandora's box.
Yes.
And so now you can see today I kind of brought in this neurogenic model into the fascia because of its innervation, right? So you can see as you sensitize the segment, now the fascia is immediately a target. So is the
Yes.
spindle. So all of that, it's kind
Yeah.
of a unifying theory. And that brings the whole discussion of fascia anatomy and physiology into the myofascial world now,
Yeah.
right? Because nobody
Well-
could really connect that. Everybody thought,
Well-
again, it was a myocentric.
Yeah, and that's
issue.
actually you had demonstrated that when we were palpating, examining, or you said this
Yes,
is myo,
yes,
but
it
this
was
is
amazing.
more sclerotogenous.
So that was an
So
example.
that's an important point to reemphasize.
So that was an example
Yeah,
today, right? So
yeah.
that was a great example because we palpate what we thought was a trigger point or whatever we palpated, and so we palpated two different structures in that same region.
Mhm.
One was the muscle
Right.
with its fascia,
Right.
and the other was actually along the joint. It was the sclerotome. It
Yeah.
was
Yeah.
it was the fibrous tissue, the periosteum even, and so it produced a completely different
Different
response.
That's right.
response.
Right.
Yes.
It produced a sort of a noxious almost response
Mhm.
to the patient. So this is the importance of understanding quality of pain.
Right.
And but to the average practitioner, they go, oh, you got pain.
Pain is pain.
Yeah,
It's
yeah,
pain.
pain.
So we just treat that.
It's pain
Yeah.
or no pain. That's
Yeah.
it.
Right.
So that's really critical, is understanding the quality of the pain, which informs what the tissue is that's being giving you the pain,
Mm.
and then you treat that differently, right?
Yeah.
Depending on where the pain's coming from.
Right.
So
Right.
it's very challenging. Mhm.
It is.
As you
And
can see.
we like a good challenge, right?
Yes.
Thank you so much, guys.
Oh, our pleasure.
you.
Thank
It's
you.
been amazing having you here in Brazil and talking with us and teaching us and spending your precious time with us.
No, it's a
I thank
pleasure.
you in our name and in the name of all the students that have learned from you.
Thank you.
Thank
Thank
you.
you for inviting us.
Yeah, thank you for inviting us. Yeah,
Thank you.
pleasure.
Pleasure.
Thank you. That good? Now, pão de queijo.